And we're going live, and it's telling me that we are live. Amazing. Hello and welcome everyone to another live. I almost again said Facebook Live, but remember, this is not just a Facebook Live. We are streaming onto all of our platforms. So welcome to our live stream today on World Diabetes Day. We are so excited to have Dr. Neville Wellington here with us today. He is a diabetes expert. He's on the board of directors of the Nutrition Network. And I'll tell you a little bit more about him and his background in just a bit. So before we dive in, I would just first of all like to encourage all of you to please say hi, tell us where you're from. If you have any questions for Dr. Neville, please put it in the comment section and we'll do our best to get to them. Also, I want to remind you, we as the Noakes Foundation, we are a non-profit organization. Everything we do, all the projects we run is really reliant on funding from private and public entities. So we have a Patreon page, and I would really like to encourage all of you to go have a look. For as little as 50 Rand a month, you can support the work that we do. So I'll ask our media team, they'll put that in the comment section. Please consider signing up to help support the work that we do. So Dr. Neville Wellington, welcome and thank you for being here with us today.
It's fantastic, Jana. Thank you for having me and welcome to everyone. And yeah, all the best for World Diabetes Day, I guess.
Yes.
Happy World Diabetes Day, it should be.
Yes, I was actually earlier today, we were at the Dunoon Clinic here in the Western Cape. And I was also kind of thinking, do we say happy World Diabetes Day? Is it a happy day? Because we're so used to say, happy this day or happy that day.
Yeah.
But I was just thinking, is that really appropriate? Is it a happy day? But I mean, we can chat about it a bit later.
Yeah.
Firstly, I'd like to introduce you. And I'm going to read it because otherwise I might miss something. So as I mentioned, we're so happy to have you here with us today, Dr. Neville. Dr. Neville is a well-respected figure in the medical community, known for his deep expertise in metabolic health and diabetes management. He has dedicated years to pioneering better treatment approaches for diabetes and is a passionate advocate for evidence-based, patient-centered care. He is currently also a Nutrition Network board on the Nutrition Network's board of directors, and he is a lecturer on several of the internationally CPD accredited trainings. So Dr. Wellington is a GP and managing practitioner at Kenilworth Medicross as an associate with 12 other GPs. He has been in practice for over 27 years now, and he has completed a 2-year postgraduate diploma in diabetes in 2012 through the University of Cardiff. And he now runs a Center for Diabetes and Endocrinology with a diabetes educator. And we are so excited to have him here with us today on World Diabetes Day to answer all of our questions about diabetes. So again, thank you for being here with us, Neville.
Thank you so much, Jana. Yeah, and it's interesting because time has flown, even since you wrote that biography. It's now 30 years that I've been in practice.
Wow, 30 years. So we definitely need to update that.
Doing diabetes. So it feels like a lifetime, but it's been a wonderful experience.
Wow. So, I mean, that's really incredible. And I really would like for us to start kind of, today is World Diabetes Day, but not often everyone exactly knows what is diabetes. We get type 1, we get type 2. What's the difference between the two? So can you give us a basic understanding of what is diabetes and what's the key differences between type 1 and type 2?
Okay. Yeah, so diabetes basically really refers to high glucose levels in the bloodstream. So whichever way you get diabetes, that's the hallmark, is that your sugar levels or your glucose levels are raised in the bloodstream. And diabetes mellitus, the mellitus is really the sweet tasting part of originally of the urine and that. But it's really just high glucose levels. And high glucose levels are defined, have been defined over many years, and all the guidelines use them. If your fasting glucose level is above 7, that's diagnostic of diabetes. If your random glucose is above 11.1, that's diagnostic of diabetes. And if your HbA1c, which is a measure of how much glucose actually damages red blood cells, is above 6.5%, that's a measure of diabetes. So whichever diabetes you have, those are the levels that you're looking at to start off with. So type 2 diabetes, maybe we should know, let's start with type 1. Let's go 1 first. So type 1 diabetes is unfortunately an issue where your body develops antibodies against your insulin producing cells. So the islet cells of the pancreas, you produce antibodies against them, and what happens is your pancreas stops producing insulin. So you need insulin to drive glucose into liver cells, fat cells, muscle cells. And when you don't have enough insulin around, the body doesn't deal with the glucose that's coming in, and even the glucose that your liver's making. And all our livers make glucose anyway because we need it. We need a small amount of glucose to fuel ourselves. We don't need too much, but we do need insulin to keep the liver from overproducing glucose, and we do need insulin to push glucose into muscles, fat, and liver. And when you don't have that, your glucose levels start to rise. And if you don't pick it up early enough, patients can become quite ill. They can develop something called diabetic ketoacidosis, and many people who've had type 1 diabetes, often that's the first time they find out that they have type 1 diabetes. Or they might just have picked it up inadvertently. They weren't feeling so well, and a clever doctor was checking their glucose and found that they were high. So that's type 1 diabetes, and the simple treatment really is replacing it with insulin. Well, simple enough. It's not as simple in practice, but that's how we deal with it. Type 2 diabetes is a little bit different in that what tends to happen is, and we know this from over long term from studies, and that a high carb intake for many years causes your body to have to clear glucose out, produces insulin. Insulin levels tend to have to rise because you keep stimulating the pancreas by eating carbohydrates, which break down to glucose, and it stimulates the pancreas to produce insulin. Insulin has to obviously try and get rid of the glucose, because actually the reason why we worry about glucose is because glucose levels are very damaging. High glucose levels are very damaging to our bodies. And so the body knows that, and it's trying to get rid of the high glucose levels by converting it into fat. So it converts the excess glucose into fat in the liver, and you end up with fatty liver, and it then pushes out into fat cells, and all the time trying to keep a normal level of glucose, which is obviously under 7 in a fasting level, and certainly less than 8 in a normal level. But unfortunately, over many years, 20 to 30 years, your body kind of loses the battle, and that's when your sugar levels, your body just can't metabolize the sugars anymore, and you start to get these high levels of glucose. So that's type 1 and type 2. So that's probably a little bit of a long explanation for the two, but type 2 is really a problem of overeating carbohydrates and overproducing insulin, whereas type 1 is not enough insulin. And usually that happens unfortunately in children, and we see that children as young as 2 years old, 1.5 years old, getting type 1 diabetes nowadays, which is very sad.
Thank you for that explanation. Right at the beginning, you mentioned something when you explained like diabetes mellitus, like the name and where it comes from. You spoke about the sweet taste.
In the urine, yeah.
Yes. So, and I think that's so interesting. Can you maybe tell us a little bit about that, and how was diabetes first diagnosed back in the days when we didn't have all of these?
Sure. Yeah, I mean, there's history from Egyptian days that they noticed that ants would congregate around urine that from somebody who was wasting away. And in fact, I think diabetes means wasting away kind of disease. There's that component to it, and then the sweetness of the sweet part. So obviously, when you're trying to get rid of high glucose levels, part of the way you're going to get rid of it is by getting rid of glucose from the urine. So when your glucose levels go above 10, we see that it sort of overflows into the urine. And so, I mean, before we had any diagnostic tests, they could taste the urine was sweet. That was diabetes mellitus. And it was that was how the ancients kind of diagnosed it. But yeah, I'm not advocating going around tasting urine.
Yes, I'm sure most of us are, well, hopefully most of us are glad that's not a practice that's no longer being used. So thank you. That is just so interesting and fascinating to kind of hear and learn about that a bit more. So you've explained to us the difference between type 1 and type 2, and I've got a question for you. It's particularly about the onset of type 1 diabetes. Because from my understanding, I've always thought like you would get diagnosed with type 1 diabetes usually at a younger age, and
Yes.
then type 2 diabetes is usually as you get older. When now I know different, but when I was a child, it was kind of like when you are old, you're going to get type 2 diabetes, and you're going to get it because your mom had it, or your dad had it, and your grandparents had it. But this morning we were at the Dunoon clinic where we did some awareness around World Diabetes Day, and we did some blood glucose testing, nutrition education, and so on. And I met a gentleman there, and I think he's at least in his early mid 60s. And he mentioned he was recently diagnosed with type 1 diabetes. And I was just wondering, could that be the case? That's the first question. And then the second question is it possible to misdiagnose type 2 diabetes as type 1?
Yes. So the answer to both questions are yes. So yes, can you get adult onset diabetes? Yes, that's well recognized. It's called LADA, latent autoimmune disease of adulthood. And so technically you can produce antibodies at any stage in your life, and you can become type 1 diabetic at any stage. Unfortunately, some people have diabetes, type 2 diabetics can, in a sense, have so much glucose around. And as I said, high glucose levels are very damaging. And one of the cells that damages your islet producing cells, your insulin cells. So somebody who's had type 2 diabetes for a long time can actually get to a point where they're just not able to produce enough insulin. In fact, at that stage, they start losing weight. They become very ill. They can even go into diabetic ketoacidosis, and because they're just not producing insulin anymore. So you can have that big rise in insulin and then slowly start dropping. And in fact, many people believe that by the time you become diabetic as a type 2, you've already lost some capacity of your insulin producing cells. Although there are recent studies that show that you can get that back by stopping the damage. So yes, but you can get somebody who's been normal, healthy, thin, can still become a type 1 diabetic at any stage in their life. So that was answering the first question. The second one, can they be misdiagnosed? Yes, certainly they can be, because we do see that where patients are diagnosed as type 2 diabetic, that they're not particularly overweight. They haven't been doing all the things that maybe type 2 is generally associated with being overweight. But very soon you see that they're just not responding to medication. They're also not responding to the dietary advice because they're just not producing enough insulin. And so usually you'll know when they first diagnosed, they might be producing a bit of insulin, and then it slowly depletes. And within about 6 months, they actually need insulin. So again, there's a transition. So they can be misdiagnosed, but it becomes very obvious fairly quickly that they actually are type 1 diabetics.
Thank you, doctor. I mean, clearly there's a lot of, I want to say, ideas and thoughts around diabetes, and especially, lay people out there who's not medical healthcare professionals. They might not know or have all the information to be able to differentiate between the different types and why you would get, one type or the other type, or like you now kind of explained how the misdiagnoses work. And I was just wondering what other type of misconceptions or myths there are around diabetes, and what type of, I would also say, like, questions or things have you heard in your practice coming from people?
Wow, but difficult to know where to start with that, Diana, because there's so many misconceptions around diabetes. Especially the original misconception was the whole thing that diabetes patients get heart disease, but they don't realize that the heart disease is due to the high glucose levels, and they get told that it's due to their cholesterol, and they must therefore go on low-fat diets, which unfortunately have an increase in carbohydrates, and things kind of get worse. And so the first real misconception that I have to deal with is really just what you eat in terms of, how you control diabetes, because we now know, and we've been preaching this for the last 15 years, 14 years, that actually low carb diets make a very, very big difference to patients who are diabetic, and to the point that many patients can go into remission, whereas nobody goes into remission on a low fat diet. It's such a low rate, whereas in our practice we did a study, we were getting 45% of patients going into remission, which is a level under 6.5%. So it's the dietary thing is the misconception to start off with, and the misconception also that cholesterol is the thing that's harming you. Yet when we look at studies on HbA1c, you get a linear increase in HbA1c, you get a linear increase in heart disease. So it's most definitely the driver, whereas you don't necessarily get that linear increase with LDL levels. So there's a lot of misconceptions around that. Then the second one that I commonly hear is that diabetics are told they can't fast and that they must eat 6 meals a day. Now, perhaps I can just deal with that one quickly, because the 6 meals a day thing came from the days when insulin was first being given to patients, and they didn't have an idea of how to really monitor their glucose readings. I mean, glucometers only came in the 1970s, 1980s when we first started using them. So for many years, the problem was, how did you control how did you know what the dose of insulin was? And your risk was that you drop your glucose levels too low, and insulin worked sort of 2 to 3 hours, and after 4 hours you'd get a low, so you'd have to eat something to keep your sugars up, and then you'd dose again. And so it became a thing to sort of practice to have 6 meals a day, and that sort of somehow just morphed into every diabetic needs 6 meals a day. And so many patients are told they must have their breakfast and a snack, and their lunch and a snack, and their supper and a snack. And unfortunately, that just drives diabetes even worse. People just can't control when they're not allowing their glucose levels to come down. It takes 4 to 6 hours for glucose levels to get right to a nadir again, and insulin levels to come down. So we have these kind of strange things that get perpetuated, but are complete myths. Some of the most common misconceptions that are out there. I don't know if you can think of others that you'd like to ask about.
So I would like to ask about one, which for me is an interesting concept, and maybe you can explain a little bit around it and tell us what you can or cannot do. And it's around having high blood sugar. So let's say you are a type 2 diabetic. Yeah. And you currently have very high blood sugar, let's say in the 20s. It's very high. Yeah. Is there anything that you can do in that moment to get it down, lower, faster? What would you, and you don't have access, let's say, to a hospital, you can't get to a clinic. And the reason why I'm asking this, it ties in with how you explain having the 6 meals, but also I spoke to quite a few diabetics this morning, and them, without knowing their blood sugar levels, and then we tested and it was very high, they would say, but no, they ate breakfast and then they had a sweet to make sure they don't get low blood sugar. And then they would ask, what do I do now? Because, obviously we're doing the reading and the blood sugar is quite high. And the question comes up, what can we do in this moment right now to bring down our blood sugar? So is it possible to do it? And if yes, what can they do?
Okay, so firstly, you are going to burn up glucose. The first thing you can do is don't go and eat anything more. So naturally your body is going to try and get your glucose levels down to under 8. That is the aim. So firstly, don't eat anything more that's going to add to that. Drink water, because you are going to be at that level. You tend to want to get rid of glucose. It's not going to come down within an hour or so. It's going to take 4 to 6 hours to really respond, and may even take a day to come down lower. But you don't have to do anything acutely. You don't have to take insulin acutely. You don't have to admit patients. The other thing I can do is do a walk, do some exercise, some resistance training. Actually brings it down quite quickly. If you just lifted some weights or did some squats or went for a nice brisk walk, you would actually be able to bring down your glucose levels fairly quickly. But the important thing is to start monitoring it correctly so that you can actually start seeing it. I mean, to be frank with you, I saw a patient just before this interview who had a glucose level of 23. And, he's on medication, but he'd eaten a sandwich and a bowl of fruit and a whole lot of things that had just spiked his sugars, and he wasn't aware because he's not been testing. And but he wasn't otherwise unwell. And patients, if they're not unwell, they're not vomiting, they're not dehydrated or anything, they can deal with it. They just must stop eating the stuff that have spiked the sugars like that, which unfortunately is the problem with the diet at the moment.
Yes, definitely. So thank you for clearing that up. I think I learned something new. So that was very interesting to know. I'm quickly going to go and head over to the comment section because I noticed we've got a few questions and we've got so many people saying hi. So I want to say hi to Wendy from Canada. She's a regular. Then I can't see a name, but I see we've got a LinkedIn user that's saying, hello, Dr. Neville. Good to see you again. And hello, Jana. So hi, LinkedIn user. I can't see your name for some reason. Emily is tuning in all the way from Namibia and saying Anouk is the type 1 diabetic. Saif
yes,
is watching.
I've had contact with them, so thank you for joining us.
Oh, yes, so you know them. So they're listening. Saif is watching from Saudi Arabia and a keto follower. Jane is saying, lovely to
I've just
see
actually
you.
had a conversation. If I can just jump in there, I just had a conversation with somebody who's recently in Saudi Arabia, and we were just talking about the high levels of diabetes and really how difficult it is to actually eat a keto type diet there. So if someone is from Saudi Arabia eating a keto diet, I want to hear how they're doing it because it seems very difficult.
Is it? Yeah, so maybe, Saif, I see if you're still watching, maybe let us know in the comments or reach out to us. It would be very interesting. I'm assuming, is it lack of access to healthy food options that's making this difficult? Let us know. It would be interesting to know. And then also, how do you go around that? And how do you then manage to eat a keto diet? And then Anne Brendan is saying hi. And then Saif is actually asking, and I'll just put the question up here, but he's asking, what about insulin fasting levels? And I think this question came up earlier when we spoke about what is the, ideal HbA1c numbers. What should that look like? And he was asking, what about fasting insulin level?
Yeah, it's an interesting question because it's not a very standardized test that's done. And unfortunately, virtually every laboratory has their own kind of levels. And as far as I know, they're measured in picometers or something. But anyway, picoliters. The one that I've seen mostly used is a level. Our lab, I think, says it's about 12 is abnormal, but I think most people would sort of aim at about under 6 as a fasting level for to see a sort of normal level. And that's somebody who's not diabetic or not type 2 diabetic, who is always trying to get their levels down. Certainly, I see somebody who's metabolically unhealthy with metabolic syndrome, they'll have levels above 20, 30, but when they start going low carb and they can drop it down, we ideally want to aim for about 6. So it is quite a useful thing, quite a useful test to do if you're trying to follow a low carb diet and you want to know, but it's not something that we routinely do. I know, some patients or some people are doing the craft test. It's also not a commonly done test yet, and trying to find where it fits in our armamentarium has been a bit more difficult.
Yes, because I see here Anne is also asking, is a blood test the only way of testing it?
Yes,
and she says she feels it's been a missing link in checking sugar levels.
Yeah, it is the only way to there is only blood testing. There's no finger prick testing for insulin levels, as far as I'm aware, yet. So at the moment, our finger pricks we can test glucose levels, ketone levels, and in fact, I've got an HbA1c meter that tests on finger prick, but not an insulin level.
Oh, that's very interesting. I actually wanted to ask you also, since you mentioned the HbA1c again, what does that stand for? I know that's a long word. And what exactly is that? So we know we need to test that, but what does it actually measure?
That's a fantastic question because there is a misconception around it. Unfortunately, okay, so it's a hemoglobin, and the A1C is it actually stands for glycosylation of the hemoglobin. It's a protein, the A1C protein. It's the A1C is a particle on the red blood cell. There's a little picture I've got here, and it looks at the protein on the red blood cells, and the more that you damage them, the more protein damage you'll see on there. You can see it on that side. So it's actually a measurement of damage to the red blood cells. Obviously, the red blood cells are in contact with glucose in the bloodstream, and that glycosylates or sticks to the protein and damages it, denatures the protein. And that is actually what we're measuring, and it's measured in a percentage. Now, the percentage can give you an idea of what your last 3 months of glucose levels has been, because red blood cells renew themselves every 2.5 to 3 months. So you can get an idea of how much damage has been happening in the last 3 months. And we've now got charts that can correlate an HbA1c to what your average glucose level would be. So for instance, I've got a little chart on here that says if your glucose level, if your HbA1c is 9%, your actual glucose for the last 3 months on average has been 11.8. Okay. So
Can you lift it a little bit more up? Sorry, I think it was just, can you lift it a little bit more up so everyone can see? Oh,
yeah, so
wow. Okay.
there's little correlation. So it's not, the problem is the numbers sound similar. So people think it's an average. It can give you an average, but it's not the average. And what they did is they took patients and they looked at their glucometer readings over 3 months. Then they got them to test. You have to test at least 4 times a day, pre and post meals, to be able to work out what your true average is for the last 3 months. Now, continuous glucose monitors are fantastic because they give us that average. And in fact, using continuous glucose monitors, you get a very close estimate of what your hemoglobin A1C is.
Okay.
Okay, does that? So it's actually, it's a very, very useful tool and we use it to see patients every 3 months, redo their HbA1c, and it tells us how well controlled they've been over the last 3 months. The aim is to use that to really motivate patients to get into remission levels, which the remission level is now widely accepted as being under 6.5%. And ideally 6.5% off all medication. That would be the ideal. So we track that HbA1c every 3 months, and it changes quite quickly. I mean, I've had a patient recently who was started at 13.3%, and 3 months later was at 6.3%, just by completely controlling their diabetes or what they were eating and doing intermittent fasting, etc. So it's very possible just through diet alone that you can actually control diabetes.
Thank you, doctor. I mean, that's a really good explanation because I think, sometimes we hear things or, we learn certain words, but it's not always clear exactly what does that actually mean. So thank you for explaining it in such a nice way so we can understand. You mentioned again diet, and you often hear people talk interchangeably about low carb, banting, keto, but they're not necessarily all the same, right? Like you get different kinds, and I think it depends on how much carbohydrates you eat. So specifically, if you have diabetes and you're diabetic, what, I want to say, type of low carb diet would you recommend?
The type that works and keeps your sugar levels down. If you're measuring your glucose levels before and after meals, you'll see very quickly how many carbohydrates you can tolerate. But generally, by definition, and we've got that in our textbook, Ketogenic, and it was from Richard Feynman's paper, I think about 12 years ago. Yes, that's the book. And he basically defined the American Diabetes Association used to say that under 130 grams a day was low carb, which we know is really not that low carb, because you will spike your sugars if you go more than 10 grams per meal. So if you want to at least lose weight, you probably need to get under 50 grams of carbs a day, which might not be quite ketogenic, but we definitely know that once you get under 30 grams of carbohydrates a day, you're going to start producing ketones, and that's where you become basically a ketogenic diet. So when you start to produce ketones, that's where your carbohydrates are low enough, and you're using your fat for energy now. You're literally switching from carbohydrates to ketones. Now, most of us will produce ketones if we fast overnight, if we're healthy, and but it's to maintain those carbohydrates, that low carbohydrate, increase your fat.
Thank you, doctor. That's so interesting, because what I'm also hearing, it might not be exactly the same for everyone. So it's such a good idea, I think, is to be able to measure your blood glucose depending on what you've eaten. And when is the best time to measure it? Like right after I've eaten something, or how much time should I wait?
So if you look at just healthy people, so we've looked at, there are lots of studies that look at continuous glucose monitoring with healthy individuals, and you'll see that their glucose levels will rise to about a level at about an hour after they start eating, and then start to come down, maybe up to an hour and a half, depending on the fat content and that of the food, how much it slows it down. And we did a study a couple of years ago, a breakfast cereal study, where we got everyone to measure 30 minutes, 60 minutes, and 90 minutes. And we found that their glucose levels peaked at about an hour. And CGM shows, I mean, some of it was quite specific, like 58 minutes was the peak. So I actually ask my patients to test an hour after they start eating, to see what the peak is, because that's one of the other myths, is they say, well, I've eaten, so it's going to be high. Well, you've eaten the wrong things. That's why it's high. You actually don't want it to spike, and in fact, you don't want it to spike more than 1.7. We kind of have a little bit of leeway. If you eat just protein and fat, you generally don't get much of a spike after a meal. But if you eat more than 10 to 15 grams of carbs, you're going to see a spike, and for some, if you're only eating carbs in that meal, you're going to see a fairly big spike.
Thank you so much for explaining that. We've got another question. I'm going to put it up here on the screen. It's from Wendy Moore, and it's a very interesting one. What are your thoughts about GLP-1s for treating diabetes? And can you explain how they work?
Okay. This is a discussion that's going to take an hour. So, but let me give you a quick heads up. I'm going to start with the second question. Can you explain how they work? So generally, the way that this has all come about, many years ago in the 1960s, they discovered something called incretin hormones. And incretin hormones are hormones that are released from the gut cells, the K cells, the L cells, and the duodenum and the jejunum, that were found to stimulate the pancreas, the insulin, and reduce glucose levels after a meal. So if you gave someone a glucose load orally, they had this insulin spike. But if you gave them the same glucose load intravenously, they didn't. And the question was, why was it not spiking the insulin as much as from the bloodstream as it was from the gut? And they discovered these hormones, and they called it incretin hormones. And from there, they discovered that the cells were releasing glucagon-like peptide, which is GLP, and from these cells. And it's basically part of the sort of first pass effect to stimulate your pancreas, sort of to tell your body almost that there's food coming along. Now, any food that you eat, whether it's fat, protein, and that is going to stimulate that. It's a bit of a myth, because they say, well, there's an insulinogenic effect of food, and there is an insulinogenic effect of all foods. It's just through the GLP-1 hormone release from the cells. So going forward, it was discovered a number of years ago that there was this glial monster that had in its saliva a product called GLP-1, and they started manufacturing this, and eventually they produced something called exenatide, and that was injected into people, and they found that actually it helped to release more insulin and help to suppress satiety and help to control diabetes better. And so we've had these drugs on the market for about 14, 15 years now. The original one was exenatide, and then there was liraglutide, and so they've become developed. What they discovered, though, so actually, let me just go back. GLP-1, when it's released from the gut cells, is actually broken down very quickly by another hormone called DPP-4/1, and so it doesn't float around for very long. It doesn't persist for very long in the bloodstream. So the stimulation effect of it is quite short-lived. But what they discovered, if you can increase the length of time that GLP-1 is around for, the effects last longer, and it also still you get the effect of the insulin producing effects from food. So it stimulates insulin when you're eating food still, but it has an increased response to food by giving the subcutaneous GLP-1 in the injections. So fast forward, we've now been able to produce these drugs even more and more, and they've now got weekly doses, and I think soon there's going to be monthly doses, and you have these high levels of GLP-1, and the side effects from those high levels are to reduce gastric emptying and to obviously stimulate insulin, but also to increase satiety. So people feel fuller for longer and they eat less, which is very much what we're trying to do by getting people to eat more fat and eating less. So that's firstly how they work. They stimulate insulin, but they also reduce gastric emptying and they reduce hunger. So what are my thoughts? Well, I have just one other thing that they do, and we do know that for quite a while, they will also reduce glucagon output from the pancreas. We know in diabetics that they seem not to suppress glucagon anymore, and that's one of the drivers of high glucose levels, is that you have this insulin is supposed to, when you release insulin, it's supposed to work on the alpha cells to down-regulate glucagon, and for some reason there's that loss of this control. And GLP-1 agonists actually seem to improve that control, and we certainly see that for a while. And in fact, I've seen in patients where they've been doing low carb to an extent, and they've got a very narrow band of glucose readings, but they're high. They tend to be between 10 and say 13. And when you put them on GLP-1s, they actually drop their set point, which is quite fascinating. So that's obviously the glucagon response that we see with the GLP-1s. So yeah, I mean, they work amazingly well for people. And I think that they certainly, I know that some people in the low carb world do use them as an induction to help patients to get into a better diet and help them to eat better and reduce satiety. The problem is that they're now advertised as lifelong drugs, which, but there are signals around gastric problems, there are signals around thyroid issues, there's signals around pancreatitis and pancreatic issues. And I'm a little concerned because I don't, physiologically, we're supposed to break down GLP-1 quite quickly, but yet we're giving patients high doses of GLP-1, which are prolonged. And I just don't think we know enough of the side effects. Recently, I was on a course through the Harvard University, and one of the speakers there gave a very interesting take on something that I didn't know about, but is now something that I'm a bit concerned. And he said that these drugs, unfortunately, when patients lose weight, they're not just losing fat weight, they actually lose muscle weight. And if they use the drug, these GLP-1s, they actually need to be doing at least 30 minutes of resistance training, a minimum of 5 times a week to maintain their muscles. Which makes you think, like, if you were just doing that anyway, you'd probably improve your diabetes. But the worrying thing is that patients may lose quite a lot of muscle mass which can have quite a serious effect. And he said you never get it back. If you lose the muscle mass, you never get it back. So I'm concerned about the drugs,
Yeah, I
but I
mean,
think there are places for it.
yeah, that is so interesting because I think it was within the last 2 weeks, someone that I know is on this medication, and this person went to get weight checked, and there was weight lost, but when they did a body scan, it showed the weight that was lost was mostly muscle mass. And
Wow.
I try to do quite a bit of reading. Like I try to do my own research around this topic, but there's not a lot going, on it. But now that you're also mentioning this, it is quite interesting. And I think maybe one of the things to consider is what you've mentioned about using these type of medications long term. That it's not supposed to be a long term, lifelong type of medication. And I agree with what you were saying, like with this diet and with this lifestyle, you can get the same results without those side effects. Yeah.
So I mean, the concern is losing the muscle mass. The other problem is that they are being promoted as long-term, lifelong drugs, and there are studies to show that if you stop the drugs, you pick up the weight again, and some people increase the weight by even more than what they started with. So that's where the kind of balance comes from. And really, I think if you're going to use a drug, you really need to be getting the diet correct. The third problem is that sometimes it's been very difficult to get hold of the drug. So patients start, they do it for 2 months, 3 months, and then they can't get hold of the drug, and then they come off again, and they yo-yo through treatment, to control, non-control. So I think until things are stabilized and we know more about the drugs, I'd probably use it more cautiously. But definitely there are patients where it definitely makes a difference. So I'm not completely against the use of them.
Thank you, Doctor. I think you gave us a very well-rounded answer to this, I think, very tricky question.
Yeah, I did.
So I see Joanne is saying, hi, Dr. Wellington and Jana. I greet you all the way from Joburg. Kieran is saying hi. He's from Ireland. Then we've got a question from the LinkedIn user, not sure if it's the same one, but asking, what about fruit as fructose is metabolized differently? And does this raise insulin levels significantly? Although it does go to the liver where it is turned into fat, as a diabetic or even a recovering diabetic, is a moderate amount of fruit acceptable?
No, so I mean, in truth, fruit doesn't just release fructose. There is glucose there as well. So it's not a complete only fructose thing. So I absolutely agree with what they're saying, in that fructose really is metabolized into fat, and it's probably, if you follow Richard Johnson's work and that, I would tend to agree that it's these high fructose drinks that we have, these high increases in fructose. And fructose, the metabolism of fructose is different to the metabolism of glucose. Fructose breaks down using fructokinase. It metabolizes, uses up a lot of ATP. ATP gets converted into uric acid eventually. And, so there's a driver there towards your increasing triglycerides from fructose use. But yes, and it doesn't specifically, if you had fructose, increase your glucose levels initially, but you may well start seeing it in the dawn phenomenon, where you start seeing this release from your fatty liver. But yeah, so a little bit of fruit, I think, if you're well controlled, and I see somebody else put the question with Paul Saladino about a meal with fruit and fatty meal. I totally agree with you. If you're going to eat fruit, eat it with the fatty meal, so that you slow down the absorption. Also, the fiber in fruit slows down the absorption of glucose. So there's reason to eat it correctly. But I think eating too much fruit and fruit on its own, I think is difficult for diabetics to control their sugar levels with. And so I wouldn't like to promote fruit only, and although I don't think you have to completely exclude it if it's going to be part of your low carb diet. We for a long time I've said no fruit. I'm probably saying a little bit more fruit, but after a meal. And check your sugar level as well afterwards to make sure you haven't spiked it.
Thank you, doctor. I'm going to jump to another question. There's some more questions, but this is more recent and it ties back into the conversation we had about the GLP-1s and the muscle loss. And Lisa is asking, would the loss of muscle mass not happen with normal dieting as well if the patient isn't exercising?
Yeah, that's a and interestingly enough, when you're doing that Harvard course, they actually said it doesn't lose as much muscle mass from dieting alone. And to be honest, I don't remember the exact mechanism, but certainly we know when on a ketogenic type diet, where you basically teaching your body to use fat for energy, not using protein for energy, you because you're eating enough fat. And somebody I know has asked about how much fat. Well, we're promoting 60% or more in calories of fat, because that's where you become ketogenic. And you need to actually protect your protein with fat. You have to teach your body to use fat for energy. So if you're going to use a ketogenic diet, we actually found in studies, and in ketogenic, there is a section on what happens when you fast, what happens when you become ketogenic, and it actually is protective of protein, so you don't tend to break down muscle that much. So but I still think you need to exercise. Yeah.
Yes. Thank you, Neville. That's so interesting. I see, and Brennan asks, how can she get her hands on a CGM? And I see the Nutrition Network answered there. Go have a look at the link they just shared if everyone else is interested in how to get your hands on a CGM. And then Elizabeth is
can I just say something there quickly, Johanna? Yes. Sorry. CDE no longer do the Libra sensors. The Libra sensors are now which are CGM, are being sold through a number of the pharmacies. I can tell you, I know that they sell at Clicks, and you can get them from there. They do have a bit of a markup. There's a place in Belleville that sells them as well. MChem Pharmacy. They're not easily available, but they are becoming more and more available now. And as many people as you can get your CGMs. The problem is they are pricey. That it's about 1,100 to 1,200 rand for 2 weeks for a Libra. Yeah. So and there are others on the market. There's Dexcom, there's Medtronic. They're a little bit more expensive, but most of them can. But the Libras are available from, I think, most.
I see you can even get them on Take-A-Lot, but then they're closer to 1,000 to 2,000 rand. But yes. So I see there's a question from Elizabeth. She's saying, you are only mentioning low carb, but what about the high fat part?
Yes.
So I think we've spoken a lot about low carb diet, and we haven't mentioned a lot about the fat. So maybe we can talk about.
I did mention the fat. Yeah. So obviously the concern around fat. Sorry.
No, go for it.
The concern around fat is that there's been this narrative that's been perpetuated for the last 50 years that high fat increases cholesterol, increases cause of heart disease. Unfortunately, that wasn't really proven. And there's been lots of studies trying to reduce fat and saying, like the Mr. Fit study and the Women's Health Initiative, and didn't actually prove that if you lowered fat in the diet that you reduce heart disease. The crazy thing is that we have a whole range of the way that patients will respond to high fat diets. So teaching patients to eat more fat. One of the things we see with diabetics is that high triglycerides. Now, if you think about it, we're converting glucose into fat, and they have the high triglyceride. They're insulin resistant because the insulins are not working that well, and the fat's meant to be stored as fat, but it keeps leaking out, and you get this triglyceridemia. But when they go into low carb diets and they stop, obviously, converting sugar into fat, we see that the body starts to burn the fat for energy and starts to actually use up triglycerides. And the ideal ultimately is that the triglycerides come down. And we see that all the time with our patients who go into sort of low carb, high fat or healthy fat diets. I'm not even sure you always have to do high fat. But so actually teaching your body to burn fat, ketones, reduces the fat levels in the bloodstream. The thing that happens is some patients, they drop their LDLs and everybody goes, wow, that's fantastic. Some of them just maintain their LDL levels, but we have these groups of patients where they increase their LDL and their total cholesterol. And as some of I'm sure that many on this podcast would know, that there's studies going on at the moment talking about lean mass hyperresponders, patients who have low triglycerides, high HDLs, and high LDLs. And are they going to have heart disease? Well, so far there's no proof to show that they are getting heart disease and that they are going to develop heart disease. So it's a fascinating world out there at the moment. So we're not worried about the fat because we believe that you need to reduce your carbohydrates. You can't increase protein too much because you don't want to be burning protein, and you want to protect your protein as fat, and you want to be burning fat because ketones are healthy, and ketones are anti-inflammatory, and they come again. People's diseases get better, and people do get better.
Yes, and I think that kind of ties in with this question we've got here from Maya saying, I've been on LCHF for probably 5 years, thanks to Dr. Noakes. I just got my annual blood results, tested on fasting for 10 hours, glucose 3.7, HbA1c 5.6, 4 plus ketones, but the LDL was 4.04, whilst the triglycerides was 0.92, and took a CT scan, calcification, and the results were 0. My question is, blood tests while fasting, can that raise the LDL? Thank you.
No, this is exactly what I was talking about. Somebody who's had almost a lean mass hyperresponder. In fact, 4 is actually quite a normal level, and certainly that's not the levels we're talking about. Lean mass hyperresponders. Those are people who have levels of 8, 10, 12. I mean, I've seen higher levels than that. And 4, I don't think the raised. Well, if there is raised, I'm not concerned about that raised LDL. And that would be causing a problem. The triglycerides are great under 1. I aim for triglycerides under 1 in South Africa. We use millimoles per liter, whereas I know in America they use milligrams per deciliter, and HDL above 1.5. So if his HDL is above 1.5 and his triglycerides are under 1, and I mean he's already proven because he's got a calcium score of 0, so he's got no heart disease. And that's exactly what we're seeing. That's what the lean mass hyperresponders are we're seeing in those patients. They're not having plaques. They don't have heart disease that we know of at the moment. But we're going to watch a space, and we've got to keep studying it. We've got to keep asking the right questions.
Definitely. And I mean, that's what we do at the Noakes Foundation. We are questioning the science and asking the right questions. Yes. So, Dr. Neville Wellington, it is 2:00. We have come to the end of our live. We had so many incredibly interesting questions today. But before we close off, I just want to give you the opportunity to maybe just share a little bit with our audience how they can get in touch with you, if they might want to have consult with you. Are there any interesting projects you're busy with you would like to share? The floor is yours.
Yeah, thank you. I am a GP diabetologist. I'm no longer doing GP work. I'm just focusing on diabetology. I have a practice in Cape Town. At this stage, I'm mainly doing face-to-face consults. So I can be contacted via the Medicross website. I work in a practice called Kenilworth Medicross. And if you go into www.medicross.co.za and you click to Kenilworth, you'll find me on there. You can make an online booking for a face-to-face. I don't yet at the moment have capacity to do online consults, but that is certainly something I'm looking at in the future because the need is becoming greater and greater, and there are just so few people who are doing what I'm doing. But hopefully, as we keep training people, as we keep doing these talks, people will eventually there'll be more practitioners who are able to do this and see the difference. I mean, once you see the difference that it makes in patients, you can't go back. And it's just for me, I've loved every minute of changing patients' lives over the last 12 years and seeing people become healthy.
Thank you so much, Dr. Neville. I just want to quickly touch on it. You're also heavily involved in the Nutrition Network. Maybe you can just, in a nutshell, briefly tell our audience what's the Nutrition Network and what is it that they offer?
Well, that's actually a fantastic question, because it ties in with what I've just been talking about. And that I think about 10 years ago, Prof. Noakes was just been overloaded with people wanting to know who to see, what to do. And I was sort of one of the first couple of practitioners, along with Dr. Kaji and others, that were starting to do the whole low carb thing with patients and seeing a difference. And we realized there's just not enough information out there, and there's not enough training out there. And so that was why we started the Nutrition Network, as a means to train doctors, diabetic nurses, dietitians along these lines, and to actually teach the science, the science behind this. And that's what we do. So that's what Nutrition Network does. We produce a number of courses looking at low carb module means to reverse diabetes. We're really wanting to reverse this trend. And so if you go onto our website, you'll see just incredible training of, I mean, I do some of it, but I'm a very small part of the people who train. There's incredible people around the world who've done so much work. And and we've I think we've had 7,000 people already do the training or more. We've had people doing the certification course who are doctors around the world that have done it, and they're teaching patients and they're teaching others. And we're having we believe, quite a ripple effect, which we are hoping is going to generate more and more practitioners, even in South Africa, to learn the science and to do the science.
Definitely. I mean, the work of the Nutrition Network has really been incredible, and to see how you have grown and your reach and how many lives you have been able to impact through this organization. The book that I held up earlier here, the Ketogenic Textbook, first of its kind. I'll ask the media team to post the link in the comments section. Go have a look. And even if you're not a medical healthcare practitioner, you can also do trainings of the Nutrition Network. And I know, a little birdie whispered, there's going to be some Black Friday specials launching soon. So please go have a look at their Facebook page, their website, go like them, go follow them, and keep an eye out for those specials that are coming soon. Dr. Wellington, again, thank you so much for being here with us today. Thanks for sharing your knowledge and explaining all these, I want to say, difficult, complex ideas and concepts to us today. We really appreciate it. And to our audience,
thank you so much, Lana. All the best.
Thank you. And to our audience, thank you for joining. Thank you for your questions. Thank you for engaging. We will see you soon. Have a lovely day further. Bye.